Okay, good afternoon, dear students. Today we plan to discuss a case of jaundice, a very important long case in the ERPM exam. So, for the students, those who are sitting for, can all of you all hear me?
Yes, sir.
All right, thank you. Perfect, thank you. Like for the students, those who are sitting for the traditional format, that is ERPM exam, long cases and short cases. In the long case, it's a very important long case that we bring for the exam. Almost every exam we bring a case of jaundice. It's very popular in final MBBS exam and also ERPM exam, KDU exams. It's a very common one. Give me a second. Yeah. Give me a second. Excuse. Right. Okay. Sorry for the interruption. Jaundice is a very important long case. Now, jaundice come up not only for medicine, it also comes up for surgery as well as pediatrics. Now, case of jaundice, like if you know very well in medicine, that will be very easy for you to tackle your surgery jaundice long case and also even pediatric jaundice long case. So, jaundice is a very important topic, like your shortness of breath, like your chest pain or fever. It's a very, very important case. And sometimes students find it difficult because we don't give full marks because students don't ask the required questions properly. So then we can't give full marks. But I'm going to give you a good overview of a case of jaundice where you have to analyze all the cases and where I will be teaching you how to get full marks in a case of jaundice. When you get jaundice as a long case in the traditional format of the exam, or even in the new format of the exam, clinicals, ERPM, the part 2 clinicals, the new format where you have the OSCE stations, jaundice will come up as history taking skills. So where they want to analyze the history taking skills, they can give you a case of jaundice. So still the questions that you got to answer, that you got to ask from the patient is very similar to the previous format of the exam where you get a long case. There also we take the questions, we ask the questions from the patient, and here also in OSCE also you ask the same set of questions from the patient. And in both instances, two examiners will be observing you. So there's no difference at all, right? Okay, right. Let's see. Uh, Mr. A 55-year-old farmer from Gampaha, presenting with yellowish discoloration of eyes and leg swelling. So Mr. A has got jaundice. He has got yellowish discoloration of sclera, eyes. The white part of the eye is called sclera, and that has become yellowish. And also he has got some pedal edema, leg edema, right? Leg swelling. So so you ask the patient, Mr. A. So the first introduction, Mr. A, what you are doing. So first you have to introduce yourself. So let me do it like in the true exam. Hello, I am a medical student, and I would like to ask some questions from you. Uh, what's your name? Where are you coming from? What's your occupation? Um, and where you are residing, right? Where you are coming from. So, මම අවසන් වසරේ වෛද්‍ය ශිෂ්‍යයෙක්. මම ඔයාගේ ප්‍රශ්න ටිකක් දැන් අහන්නයි යන්නේ. ඔයාගේ නම මොකද්ද? වයස කීයද? ගම්පලාත කොහෙද? මොකද්ද රැකියාව වශයෙන් කරන්නේ? So then you ask presenting complaint. What is the main complaint which brought you to the hospital? මේ පාර ඉස්පිරිතාලයට ආපු ප්‍රධානම ප්‍රශ්නය මොකද්ද? ප්‍රධානම අමාරුව මොකද්ද? මේ පාර ඉස්පිරිතාලයට ආපු ප්‍රධානම අමාරුව. Presenting complaint. And also you have to ask the presenting complaint duration. So Mr. A presented with, so he says, doctor, my eyes are all yellow. And also when I pass urine, that is very dark in color. or and also I got the swelling of my feet. That is why I came to the hospital. There may be plenty of other complaints. They might complain of some runny nose. They might complain of headache. They might complain of some vague muscle aches and pains, joint pains, things like that. I mean, every patient, those who are walking into the wards, they will have back pain. Everyone will have some joint pains. Everyone will have, like anyone with any medical problem, will have some, myalgia and arthralgia. It's so common. But whether we are going to pay a lot of attention to arthralgia, myalgia is questionable. No, it's not. Because the thing is, if you get carried away with arthralgia and myalgia, what patient is going to say, you are going to lose your track. So a good intelligent medical student will identify what the main problem is. And you will go along the main problem to tackle the main problem, not the other subsidiary or like the minor complaints. Say, for example, myalgia, arthralgia, fatigue. ඔලෙඩ්ඩු කියනට හැමතිසම ඩොක්ට මගේ ඇඟ පත රිදෙනවා කොන්ද රිදෙනවා මේ දනිස්කක් කියනවා වැඩක් කරගන්න බෑ හරි ඇඟට අප්‍රාණිකයි ඉතින් ඒ ඔක්කොම තියෙනවා ඒ jaundice ඇතුළත් තියෙනවා shortness of breath ඇතුළත් තියෙනවා chest pain ආවත් you get that if you get headache also you get that you get seizure you get that you get rheumatoid arthritis you get that you get SLE for all that you will get this myalgia arthralgia loss of appetite feeling fatigue malaise medical students also have that too. Yeah, medical students also have that. Teachers also have that. Right. So that's common to everyone. Right. You're not going to get carried away with those minor symptoms, but you're going to get carried away. You're going to focus on what's your main focus? The yellowish discoloration of sclera. So a good, intelligent medical student should understand this is the main problem. It is not myalgia or arthralgia. It is the jaundice. It's the yellowish discoloration of sclera and leg swelling. They are not simple symptoms. If a patient comes and complains of swelling of my feet, or doctor, I have got swelling of my feet, you have to really, really, really go behind that. Why ankle edema is a very important medical entity. If a patient complains of jaundice, that's also a very important medical entity. So you have to you have to focus on that direction. So Mr. A presented with worsening jaundice for 2 months duration. Worsening jaundice. Doctor එන්නෙන්නම මගේ කහපාට මේ ඇස් ඉස්සෙල්ලම ලා පාටට තිබුණේ. දැන් එන්නෙන්න කහපාට ගතිය වැඩි වෙලා. So worsening jaundice. Worsening yellow eyes for 2 months. He also noticed swelling of his feet for 3 to 4 months duration. So the leg swelling has begun a little earlier. The jaundice has come up little afterwards. So yeah, if you got a patient with, so I'm going to ask you questions. So this is an interactive session. So I want students' participation today, right? I did tell you that I'm going to do an interactive session, but I just want you to come up with thoughts, ideas. So like you can even unmute yourself and or you can show yourself and you can start talking. So if you got a patient with jaundice like this, as presenting complaint, how do you evaluate his history in order to find differential diagnosis? What are the questions you are going to ask? What questions should be asked during the systemic review? So now, when it comes to the presenting complaint, what further questions should you ask in order to evaluate a differential diagnosis? What questions should you ask from the patient in order to focus a differential diagnosis during the systemic review? So, of course, all this is there in your theory lecture notes, in ERPM theory, and even the clinical component we have this, but theory, like this is theoretical stuff. No? Theoretical stuff also you need to know. That's how you ask questions based on those theory knowledge. So refer to the abdominal lecture notes, where we have done hepatobiliary system. I have done a nice lecture on jaundice. How to evaluate jaundice? I have put up a nice diagram also. How to evaluate jaundice? So jaundice is a separate topic that I have done. So you can go through your previous theory lecture notes and see how I have evaluated jaundice. Right. So can students talk now? Yeah. So I'll give 5 minutes. We'll make it an interactive session, or not 5 minutes, just 3 minutes. Right, guys. Can you unmute yourself? Can you please unmute yourself and can you open up your videos, like, so can you can show your faces and we can make it interactive session? Yeah, please, without wasting time. Yeah, hurry up. So tell me few questions. Yeah. Then only this will become a very fruitful session. Yeah. So can students talk? Yeah. So what questions are you going to ask from a patient with jaundice? Hurry up, please. Yeah. Tell. ලෙඩා කියන්නේ ඩොක්ටර් මගේ ඇස් දෙක කහ පාට වෙලා කකුල් දෙක ඉදිමිලා. So we are not going to concentrate on leg edema. I am asking you questions. If you get a patient with jaundice, if you get a patient with yellow eyes, what questions are you going to ask from the patient?
So first, whether it's a surgical jaundice or medical jaundice.
Very good. But so first, yeah, that's a very important thing. You have to find out whether it's surgical jaundice or medical jaundice in order to get a differential diagnosis. So what questions are you going to ask? You can use any language.
When was it first diagnosed? How was it diagnosed? Was it intermittent or progressive?
Sorry.
What is the urine color?
Yeah.
When was it when was it first diagnosed? How was it diagnosed? Was it intermittent or progressive? How
Okay.
long you're having this? How was the progression? What is the urine color? What is the stool color? Is there any pruritus? Are there any anemic symptoms?
Yeah. Any other questions? Yes. Any other questions? Suddenly, I think
So whether the loss of appetite and loss of weight, if it's like obstructive
yes.
jaundice.
It is obstructive jaundice, and also particularly if it is a malignant case, like say
Yes.
hepatocellular carcinoma or carcinoma head of pancreas or gallbladder carcinoma, cholangiocarcinoma, you will have loss of appetite and loss of weight. Very good. Yeah. What else?
And the fever present or not?
Correct. Because some of the cases of jaundice are due to hepatitis. So hepatitis can be infectious focus. So if it is infectious focus, you will have fever. Very good. So along with fever, one more thing, if you are suspecting hepatitis, you are doing good. Like
Pruritus.
pruritus, of course, for surgical jaundice, you can get pruritus, but if it is acute hepatitis, like where you get fever, then the other important one is abdominal pain, no? Right-sided abdominal pain.
Yes, hepatomegaly.
Anything else about habits?
So
Are you
recent travel
Yes, travel history because
and
they would have traveled to areas where there is hepatitis, so they would have contracted hepatitis after traveling to those areas. Maybe then what else?
blood transfusions.
Correct, very good because hepatitis C infections or even hepatitis B infections can be due to previous emergency blood transfusions. You are right.
Consumption of unhygienic food and water.
Yes, very good. Also, intravenous drug uses, no? Intravenous
IV drug use. Yeah.
promiscuity, so there could be HIV, hepatitis B and C infections which have been transmitted sexually. So that would be important. Then also you need to ask about alcohol. So that's one main area that you need to question because there's a fairly big number of patients those who have consumed alcohol and getting alcoholic cirrhosis and alcoholic hepatocellular carcinoma, isn't it? So you need to ask about alcoholic stress. Well, what else?
so habits? Are you washing hands after going to the toilet?
Sorry?
Are you washing hands after going to the toilet? Like habits
Yeah, you can
to
ask that.
exclude hepatitis.
Yes. Infectious hepatitis, yes. Hepatitis A. And also,
Ayurvedic medication.
correct.
Ayurvedic medications.
Ayurveda preparation, like particularly drugs like Arishta or Kasaya, because those they get converted to alcohol. So, like if you have consumed Ayurvedic preparation over a long period, you have a tendency to develop liver disease. That's good. And also other medications like for arthritis we use methotrexate, tuberculosis we use drugs like rifampicin. They also can cause hepatitis, right? So good. I think students participated very well. Your thought process was good. So like good. Yeah, so those are things that we need to ask. So let's see the next slide. So here I have shown you a slide how to evaluate jaundice. So my dear students, when you get a patient with jaundice, like the jaundice can happen in three places. Either it can be before the liver, so or within the liver or after the liver. So we call it prehepatic jaundice, intrahepatic jaundice, and we call it cholestatic jaundice. So the intrahepatic jaundice, cholestasis can occur intrahepatic, that is within the liver, or it can occur outside the liver, then we call it extrahepatic cholestasis. So extrahepatic cholestasis is the one that we talk mainly as surgical jaundice. Extrahepatic cholestasis is the one, this one is the one that we mainly label as surgical jaundice. And medical jaundice is the prehepatic jaundice. So let's go through this very quickly, this theory. So if you take prehepatic jaundice, that is before reaching the liver, so where do you have breakdown of your or release of bilirubin? Because bilirubin is the substance which makes you look jaundiced or look yellowish. So it's the red cells. You know, during the red cell breakdown, or what you call hemolysis, right? Hemolysis, either it can occur in the spleen or it can occur within the blood vessels. If it occurs in the spleen, we call it extravascular hemolysis. If it occurs within the blood vessels, we call it intravascular hemolysis. So what are the two terms? If the breaking of red cells occur within the blood vessels, we call it intravascular hemolysis. If it occurs within the spleen, if the breakdown of red cells occur within the spleen, we call it extravascular hemolysis. So during the hemolysis, the hemoglobin breaks down. Heme and globin. Globin is the protein. The heme gets converted to biliverdin and the biliverdin gets converted to bilirubin. So bilirubin is soluble and bilirubin will be taken up to the liver. You can see here hemoglobin, then the bilirubin is released. Bilirubin is taken up by the liver. So this bilirubin, it is not like bilirubin is not water soluble like your the conjugated bilirubin. So this is what we call unconjugated bilirubin. So initially what you get during hemolysis is called unconjugated bilirubin. Unconjugated. It's not conjugated. What do you mean by conjugated? Conjugation occurs within the liver by enzymes. Those are called glucuronidase enzymes. Glucuronidase enzymes, they make bilirubin conjugated. But before reaching the liver, this bilirubin will be there in the bloodstream, and that's called unconjugated, or we call it indirect bilirubin. So indirect bilirubin is not that soluble. So it is soluble to some extent, but it is not water soluble as we see in conjugated bilirubin. So therefore, when you get medical jaundice or hemolytic jaundice, during hemolysis, if you have increase of bilirubin, then jaundice is not very deep, just slight tinge of icterus. You would have seen patients with thalassemia minor or thalassemia intermediate, they get just mild jaundice. You would have seen patients with hereditary spherocytosis, you would have seen patients with SLE, they only get very mild tinge of jaundice, right? Very important these words, mild tinge of jaundice. Whereas if you get jaundice within the liver or after the liver, that is mainly conjugated bilirubin or what we call direct bilirubin. And that is very nicely water soluble. Therefore, that can get deposited with the tissues and that can give rise to deep jaundice. So, conjugated bilirubin causes deep jaundice, right? So, okay. So, hemolysis. So, now we learned one important term, hemolysis, either extravascular in the spleen or intravascular within the blood vessels. It can cause jaundice. Not deep jaundice, it's only mild jaundice. So, when you get this hemolytic jaundice, so patients will complain of symptomatic anemia. Why is that? Because the red cells break down, so therefore you lose hemoglobin, therefore you have lack of hemoglobin and that causes anemia. So you have anemic symptoms. What are the anemic symptoms? Fatigue, malaise, headache, loss of appetite, things like that. So mainly they complain of fatigue and also easy tiredness, weakness, generalized weakness, things like that. Or there may be history of blood transfusions in the past. Why? The patient, if they have got hemolytic jaundice in the past, we would have given them blood transfusions in order to correct it. right? And then also sometimes the doctors would have prescribed iron medications, iron pills. So just ask them whether they were given iron pills or whether they were given blood transfusion or when there's a family history, like say for example thalassemias, or there may be a hereditary spherocytosis where the family history may be positive. So you have to ask for family history as well, right? Okay. And also you can ask for left-sided abdominal fullness. Why left-sided abdominal fullness? For splenomegaly. Splenomegaly. So those questions only you should ask when you're focusing hemolytic anemia, hemolytic jaundice. Then when it comes to cholestatic jaundice, either intrahepatic or extrahepatic, that is called the cholestatic jaundice. So during cholestasis, you produce water-soluble bilirubin or conjugated bilirubin. So what are their features? They produce pale stools. Why? Because that water-soluble bilirubin does not get drained adequately into the second part of duodenum via ampulla of Vater. Here, this part. Here, is not getting released into the second part of duodenum and to the intestines. So therefore, the stool will not get their normal color. So therefore, you get pale stools. But this bilirubin is water soluble. So therefore, that gets released into the bloodstream and then to the urine. Therefore, urine is very dark in color. So they complain of plate colored urine or dark colored urine. So they get pale stools but dark urine. And also these water-soluble bilirubin get deposited just under the skin, beneath the skin, and therefore that causes pruritus, itching, right? So those are the classical symptoms. And sometimes this cholestatic jaundice can be due to malignant cases. So malignancies can cause loss of appetite, severe loss of appetite, loss of weight. The patient may be cachectic. Patient might complain of neck lumps. Why? Particularly the left-sided neck lump, the Virchow's node here, the supraclavicular lymph node or the Virchow's node. You know, when you have GI malignancies, you can have a left supraclavicular lymph node or what you call Virchow's node. So you can ask for neck lumps, particularly on the left side, or even just neck lumps. Right. So here, just to give you some heads up on theory, so intrahepatic cholestasis is mainly due to hepatitis and cirrhosis. So the problems with the liver. So liver diseases can be acute or chronic. So acute liver diseases like acute hepatitis. Acute hepatitis can make you get jaundice. So acute hepatitis can give rise to jaundice. So acute hepatitis can be viral hepatitis, it can be leptospirosis, it can be drug-induced hepatitis, it can be alcoholic hepatitis. So any of those are acute hepatitis. Then also pregnancy-associated hepatitis. Then guys, you have chronic liver cell disease, chronic jaundice due to chronic liver disease. So chronic liver cell disease or what you call cirrhosis. That is where the liver starts shrinking. In hepatitis, the liver gets enlarged in size, liver is swollen, but when you get cirrhosis, the liver is shrunken, right? You get a shrunken liver. So when you get cirrhosis, so due to that deformed architecture, again the bile canalicule can be obstructed, and you get obstruction of the bile flow, and you can end up with jaundice. So that is again cholestatic jaundice or obstruction. So the patient with CLCD or cirrhosis, they will also have what are the key things to, or what are the key things for hepatitis? What are the key things for cirrhosis? Key things for hepatitis would be fever, anorexia, that is loss of appetite, fever, anorexia, and right-sided abdominal pain. Fever, anorexia, and right-sided abdominal pain for hepatitis. Then what about for cirrhosis? Cirrhosis patient will also have leg swelling, pedal edema, and also they will have abdominal swelling or what you call ascites. So the cirrhotic patient will have ascites, that is abdominal swelling. The cirrhotic patient will also have leg swelling or pedal edema. The cirrhotic patient will also complain of sometimes loss of hair in their chest. They might complain of enlarging of their male breast. The male breast have got enlarged, this gynecomastia. They might complain of those complaints, but not always. But the most important things are leg swelling and also abdominal swelling. Then also the patient with cirrhosis, they might present with complications of cirrhosis, like say for example, hematemesis and melena. They might complain of vomiting brownish colored vomitus, or vomitus with the brown colored stuff, or black tarry colored stools, melena. Then they might also complain of alteration of sleep pattern, like where they are more drowsy during daytime and they are restless during night time. Right. Then, guys, so that is intrahepatic cholestasis. That is the defects of the liver, either acute or chronic. You understood? So, what are the common causes of cirrhosis? Yeah, the commonest cause of cirrhosis in the world is, yes, what is it? Interactive.
It's a non-diabetic hepatitis.
Yes. NASH. So, the commonest cause of cirrhosis in the world is NASH cirrhosis. Then that is followed by alcoholic cirrhosis. So NASH cirrhosis, alcoholic cirrhosis, then hepatitis B, hepatitis C, things like that. Okay, autoimmune hepatitis, things like that. Right. Then you have surgical causes of jaundice, and the obstructive jaundice. So either problem of the common bile duct or problem with gallstones. So common bile duct can get obstructed. This common bile duct can get obstructed either due to stones, gallstones, or it can get obstructed because if you get a carcinoma of the head of pancreas. So if you get a carcinoma of the head of pancreas, the proximal part, the distal part of the common bile duct will get obstructed, and there will be dilatation of the common bile duct. Even from a stone, if you have a distal obstruction of the common bile duct, you will get dilatation of the common bile duct, usually more than 10 millimeters dilatation. So CBD dilatation can occur either due to obstruction by gallstones or due to obstruction by a carcinoma head of pancreas. Also, you can have surgical jaundice due to cholangiocarcinoma, either gallbladder cancer. They also can cause, that's cholangiocarcinoma, they also can produce surgical jaundice. So here you can see the second part of duodenum, ample of weight. Sorry, here second part of duodenum, ample of weight, and there the flow of bile will be obstructed. Therefore, you get pale stools. Right, that's the reason. Right. So that's about theory on jaundice. Right. So evaluation of jaundice. What questions should you ask from the patient? Right. So number one is duration of jaundice. So you ask the patient, කොච්චර කාලයක් දැන් මේ ඇස් කහ වෙලා තිබුණාද? Patient says 2 months. Is it progressively worsening or intermittent, or is it improving? Is the jaundice getting better? Is it reducing now? මේක වැඩි වෙනවද? මේ ඇස් කහ වෙන එක ඉන්න තද වෙනවද? තද පාට වෙනවද ඇස් දෙක? කහ පාට ගතිය. නැත්නම් ඒක ඉන්න ඉස්සෙල්ලා තද වෙලා තිබුණ දැන් පාට අඩු වෙගෙන යනවද? නැත්නම් මේක වරින් වර දෙන්නේ. ටික දවසක් කහ පාට වෙනවා ආයෙත් හොඳට තියෙනවා ආයෙත් කහ පාට වෙනවා ඒ විදිහට දෙන්නේ. So that is intermittent jaundice. Intermittent jaundice can be important surgically, you know that condition, Mirici syndrome, right? Right. So that those questions you do. So you ask for the duration of jaundice, you ask for the nature of jaundice, with is the progression of jaundice. Is it worsening? Is it reducing? Or is it improving? Or is it intermittent? Then also you have to ask the jaundice whether it's a painful jaundice or a painless jaundice. Why? Painful jaundice is where you get abdominal pain, right hypochondrial pain. So along with jaundice, if you get right hypochondrial pain, that more suggestive of acute hepatitis, right? Along with jaundice, if you get right hypochondrial pain, that is more in favor of hepatitis. But also it can be due to hepatocellular carcinoma. Liver cancer also can cause right hypochondrial pain. Acute hepatitis also can cause right hypochondrial pain. But you get more sharp pain during hepatitis. You get a dull pain in hepatocellular carcinoma. Right. So painful or painless jaundice. So now conditions like cirrhosis or conditions like some of the other malignancies, they cause painless jaundice. Then also you need to ask whether fever is present or not. So the people with acute hepatitis, they will invariably have fever. The people with acute hepatitis, they will have fever. Most of the cases, not all. Like particularly the infectious causes like viral hepatitis, leptospirosis, they will have fever along with jaundice. So fever is more in favor of acute hepatitis due to an infectious process. Then very correctly you are told this, you have to ask about whether it's a surgical jaundice or a medical jaundice. So surgical jaundice or what you call cholestatic features. You need to ask whether the patient has got cholestatic features. So you ask pale stools, dark urine, pale stools with steatorrhea. You ask වගේ basically යනකොට කක්ක යනකොට පාට අඩු පාටට දෙන්නේ සුදු පාටට වගේ දෙන්නේ කිරිබැටි වගේ සුදු පාටට දෙන්නේ. ඒක මේ ටොයිලට් එකේ ෆ්ලෂ් කරන්න අමාරුද හුඟක් ගඳට දෙන්නේ. Why these smelly bulky stools? Smelly bulky stools can be due to impaired lipid digestion and absorption. Steatorrhea. Because bile is important for lipid digestion and absorption. So due to lack of bile, your lipids won't get digested. Lipids won't get properly absorbed. So there'll be a lot of lipid fat content in your stool. If you get a bulky stool, which is very smelly and also it's difficult to flush. It floats. That's called steatorrhea. Then also ask for dark urine, where the patient got dark, plainly colored urine, and also ask for pruritus, itching. Those are features which favor cholestatic or obstructive jaundice. Then ask for hemolytic features, which I already told you. Ask for symptomatic anemia, history of blood transfusions, any joint, any iron pills already been prescribed. Then ask for features of cirrhosis, chronic liver cell disease or cirrhosis. So you ask for swelling of abdomen, that is ascites already. I told you swelling of feet, ankle edema, history of coffee-colored vomiting, that is hematemesis, history of melena, black tarry-colored stools. Then ask for history of previous parasite disease, where the doctors have, in the past, where the doctors have pricked the abdomen and taken fluid out of the abdomen. Because if the patient has undergone that, patient will definitely remember that. So just ask the patient, වගේ බඩ බිඳලා වතුර අරගෙන තියෙනවද එළියට? cans පිරෙන්න වතුර අරන් තියෙනවද? Usually we drain that ascitic fluid into cans, because usually we drain about 4 liters in one go. So you ask whether doctors have performed parasite disease on you. You don't ask parasite disease, you ask whether doctors have pricked your abdomen and taken fluid out of your tummy. Then also ask for daytime drowsiness. Why? There is an altered sleep pattern. Daytime drowsiness can be due to hepatic encephalopathy. And do you have difficulty falling asleep during night time? Whether you have difficulty in falling asleep during night time. There's reversal of sleep pattern. Then we need to ask about etiology of cirrhosis. Now, say, for example, you found this patient has got cirrhosis. Then you have to ask for etiology of cirrhosis. What are the etiologies of cirrhosis? So, as I told you, history of fatty liver disease, like NASH, history of alcohol consumption, you must ask the patient. So, you examine. Now, alcohol history, usually we get it under social history. But here, guys, what we are going to do is that important parts in the social history, we are going to ask right now, because we want to make a differential diagnosis, right? So you don't have to go in compartments, past medical history, past surgical history, allergic history, family history, drug history, social history, nothing like that. If it is related to the history of presenting complaint, if it is related to making a differential diagnosis, some of the habits you can ask much earlier, like here. So ask about alcohol habits. So alcohol consumption, whether he's a daily drinker or whether he's a social drinker, whether he's a daily drinker or whether he's a social drinker, whether he has got features of alcohol dependency. The patient says yes to alcohol, then you must ask for features of alcohol dependency. Like that is, how do you ask for features of alcohol dependency? Whether they got tremors in the body and whether they need to drink daily at the same time every day. That's called stereotype drinking. These are some features of alcohol dependency syndrome. So ask for alcohol habits, ask for features of alcohol dependency syndrome, and also withdrawal features. Any past history of hepatitis, where the patient has got any hepatitis in the past. අක්මාවේ ඉදිමීමක් අක්මාවේ ලෙඩක් ඇතිලා අක්මාවේ ඉදිමීමක් වෙලා තියෙනවද මීට ඉස්සෙල්ලා. Where the patient has consumed any Ayurveda medications for long periods, or any other Western medicines, where the patient is taken for rheumatoid arthritis or even pulmonary TB. Like when the patient has been on any methotrexate for a long period, and also when the patient has got tuberculosis and whether he's been treated with rifampicin. Why we all know rifampicin is hepatotoxic. Not only rifampicin, even isoniazid can be and pyrazinamide can be hepatotoxic, but male is rifampicin. Right. So, and also ask about foreign travels. When the patient has traveled abroad recently. Now, one student might ask me, sir, then why you are not asking about sexual history right now? The reason is whenever you ask about sexual history, because you are not asking whether you are going to have very glamorous sex or anything like that, we are going to ask whether the patient has got sexual promiscuity. So, sexual promiscuity is a bit of an embarrassing question, and that you are going to ask at the last as the last point, right? Yeah, because you should not embarrass the patient. Then they will not give some important vital information. Right. Then also features of malignancy. So you need to ask about loss of appetite, loss of weight, whether they remember their weight loss. Some patients might say, Doctor, 3 months before my weight was 65, but now I have lost about 10 kilos and now I am almost 55. So that's a very significant drop of weight. Then also ask for any neck lumps, whether he has noticed any neck lumps. That is cervical lymphadenopathy. Right. So then you have to do the routine systemic review. What is the routine systemic review? Like you ask for cardiovascular system, you ask for when the patient has got any chest pain, when the patient has got any shortness of breath. Then for respiratory system, you can ask when the patient has got any cough with wheezing, when the patient got any diarrhea for abdomen. Then for nervous system, you can ask when the patient has got any seizures. That's important, guys. Why? Hepatic encephalopathy sometimes can precipitate seizures. So ask for any history of seizures. And when the patient has got any peripheral neuropathy, why? If it is cirrhosis, cirrhotic patients, they can end up with peripheral neuropathy. So ask for that. Right. So that way you are going to do the systematic review. Then the past medical history, you must ask about diabetes, dyslipidemia, hypertension, liver diseases, arthritis, and tuberculosis. So why do you have to ask about diabetes, dyslipidemia, and hypertension? Because guys, these are the main risk factors for causation of NASH cirrhosis. Non-alcoholic steatohepatitis, one of the leading causes are diabetes and also high cholesterol. So metabolic risk factors whether they are present, right? That we are going to ask. And also whether the patient has got any past history of liver disease, arthritis, or TB. Past surgical history, any abdominal surgeries, whether the patient has already undergone any abdominal surgeries in the past. The allergic history, whether the patient has got any food or drug allergies. Then you need to ask about family history of liver diseases, where the patient had any, because there can be familial cases of cirrhosis. So you have to ask for family history of liver diseases. Where the patient has got any family history of abdominal malignancies, there may be liver cancers. So you need to ask about family history of abdominal malignancies. In the social history, if you have not asked previously about alcohol, better you ask that, because a patient with jaundice, if you don't ask about alcohol, we will definitely fail you. That's a very bad mistake. A patient with jaundice, if you do forget to ask about alcohol, it's a huge mistake. Right. So social history asks about alcohol, smoking habits, recreational drugs like intravenous drug usage, and also sexual promiscuity. So those are the questions that you got to ask the patient. So what are the differential diagnoses, guys? What are the differential diagnoses that you got? Yeah. So as I told you before, hemolytic anemia, that is before reaching the liver, indirect or unconjugated hyperbilirubinemia. So medical jaundice. It's due to hemolysis, hemolytic anemia. So hereditary causes can be there, like hereditary spherocytosis, thalassemias. Then there can be acquired cases, acquired causes of hemolysis like SLE. So for SLE, what questions should you ask? You have to ask about the rashes on the face, with photosensitive rashes. When you are exposed to sunlight, you get rashes. Do you have loss of hair, alopecia? Then
Joint
ask,
pain, oral ulcers,
yeah, small joint arthritis, oral ulcers, very correct, very good. Frothy urine, things like that. You don't have to ask all the questions, but few questions. So, as you told, rashes, alopecia, small joint arthritis, and oral ulcers. Then ask for, yeah, so that's for hemolytic anemia. Then for hepatitis, you will ask for fever, anorexia, abdominal pain. Those are leading symptoms, fever and right hypochondrial pain, along with some anorexia. So for infectious focus, you can ask, as you are told before, like about their sanitary habits, whether they wash their hands, clean their hands before their food habits, sanitary practices. Then you need to ask definitely on alcohol consumption, which I told you before, whether the patient has been on any drugs. And also fatty liver. That's for hepatitis. Then, guys, for chronic liver cell disease or cirrhosis, you need to ask whether they are ascites. So the things which are favored in this particular diagnosis, cirrhosis will be favored with abdominal swelling, but in hepatitis you don't get ascites. So hepatitis per se, you don't get abdominal swelling. Okay, but cirrhosis will lead to development of ascites and abdominal swelling. Ankle edema, that's also mainly favoring cirrhosis. Alcohol habits, fatty liver, hematopoiesis or melena, reversal of sleep pattern, that is for chronic liver cell disease complication, that is hematopoiesis and melena, and also hepatic encephalopathy. Malignant cases, malignant causes ask for loss of appetite, loss of weight, neck lumps, deep jaundice, features of cholestasis. So these things will favor those respective differential diagnosis. So what are the DDs? Hemolytic anemia, hepatitis, cirrhosis, and various malignant causes of jaundice like carcinoma head of pancreas, biliary carcinoma, what you call cholangiocarcinoma, hepatocellular carcinoma, right? Things like that. How do you investigate a patient with jaundice? What are the investigations that you carry out in a patient with jaundice? Yeah. So, how do you organize your investigation? First of all, so you must tell the examiner, I would like to do some basic hematological investigation like full blood count. In the full blood count, I am going to have a look at the hemoglobin. And also, I'm going to have a look at the platelet count. Why? Hemoglobin will be low if it is hemolytic uh, jaundice. And also, it will be low if it is following cirrhosis as well as liver or other GI malignancies. Then platelet count will be low if it is a case of cirrhosis. Cirrhosis patients, they have splenomegaly and therefore the platelet count would be low. Thrombocytopenia is very well expected in patients with cirrhosis. Then you will do the retic count blood picture. Why retic count and blood picture will be very important if you are suspecting hemolytic anemia. So retic count will be increased, elevated, and the blood picture will show polychromasia if it is hemolytic anemia. Then also if the retic count is elevated, I will go and do a DACT or direct antiglobulin test or what you call direct Coombs test. Because if the retic count is high, then you must do the Coombs test. And if the Coombs test is positive, you call it Coombs positive hemolytic anemia, which is autoimmune hemolytic anemia. So those are the blood tests that we do mainly for evaluation of medical jaundice. Then you will do ESR. Why? If the ESR is very high, you must suspect malignancies. Then of course you have to you have to quantify the bilirubin jaundice. So for that you do the total bilirubin, direct bilirubin, and then you can calculate the indirect bilirubin. So total and direct bilirubin. So total bilirubin will be elevated, and also direct bilirubin will be elevated in intrahepatic cholestasis and and also intrahepatic cholestasis and extrahepatic cholestasis. That is the causes within the liver and also after the liver, right? The surgical jaundice. Surgical jaundice, surgical jaundice, there can be uh, elevated total bilirubin as well as direct bilirubin. You got my point? When there is surgical jaundice or obstructive jaundice, the total bilirubin is also high and the direct bilirubin is also high. Direct fraction. Why? Conjugated bilirubin. If it is hemolytic anemia, mainly the indirect bilirubin will be elevated. In hemolytic anemia, mainly the indirect or unconjugated bilirubin will be elevated. That's why we have to do the total and direct bilirubin levels. You also need to do the LFTs, liver function tests, or what you call the liver profile. In that, you are going to see the AST-ALT. With the AST is higher than ALT. AST will be higher than ALT if it is a case of cirrhosis, right? And also you want to have a look at the albumin globulin and albumin globulin ratio. The albumin level will be low if it is a case of cirrhosis, right? Albumin levels are going to be low if it is cirrhosis, and the albumin globulin ratio is going to be below 1. Albumin globulin ratio is going to be below 1. Right. And if it is a case of, now write down these things are very important. If it is a case of obstructive jaundice, particularly due to a malignant cause like carcinoma head of pancreas, biliary carcinoma, things like that, or hepatocellular carcinoma, in that case, your alkaline phosphatase and gamma GT would be very high, or what you call disproportionate elevation. So disproportionate to the transaminases, that's AST and ALT, your GGT and ALB will be very much elevated. So that's how we analyze the LFTs, liver function tests. You also do the prothrombin time and INR. Why? If it is a liver injury, liver damage, the prothrombin time, the clotting factors are also going to get damaged. So factor 7 represents the INR, prothrombin time. So the prothrombin time and the INR is going to get prolonged. And that can cause even bleeding manifestation. Then the other very important investigation is ultrasound scan of the abdomen. You do imaging of the stomach, the abdomen. So imaging will help you to identify whether the patient has got cirrhosis, right? Imaging will help you to identify whether the patient has got cirrhosis. So if it is hepatitis, the liver will be swollen. If it is cirrhosis, the liver will be shrunken. Then imaging will also show you whether there are any other malignancies like carcinoma head of pancreas, gallbladder carcinoma, things like that. And also that will show you CBD dilatation, common bile duct whether is dilated or not. So CBD dilatation can occur due to malignant causes and also due to gallstone obstruction. So yeah, and also last but not the least, the ultrasound scan abdomen will also show if the patient has got any ascites and also if the patient has got a splenomegaly, keeping up with cirrhosis, and also whether there are any paraiotic lymph nodes, because this may be a case of jaundice due to a lymphoma or it can be due to malignancy. So you must look for paraiotic lymph nodes as well. Yeah. Okay, guys. So I think that's the way you need to evaluate a case of jaundice. So yeah. So during this 1.5 hours, oh yeah, almost 1 hour and 50 minutes, we evaluated the case of jaundice. So now you know how to take history, a detailed history in a patient with jaundice. What questions should be asked? How do you make a differential diagnosis? And to make a differential diagnosis, what type of questions you should ask? All that I have discussed with you. So if you get a case of jaundice, now you can definitely pass with flying colors, and you can definitely you know make the examiner happy when you ask these questions, because they are expecting these questions from you. And if you have asked that, they'll be so happy. And definitely you will be awarded a very good mark finally. Right. Okay. Any questions for me?
Sir, can we add malaria as a differential diagnosis if the patient has a history of long-term travel?
Yeah, I think malaria is also one of the cases that we have to suspect. Very correct, because if the patient has got travel history, they would have traveled countries like Africa or other tropical countries where the malaria is endemic, and then you must think of malaria as well. But we got broad categories of differential diagnosis, so it also comes under hepatitis, either viral hepatitis or leptospirosis, malaria, rickettsia. They all can cause acute hepatitis. But you are correct.
What is the common DD we get in the exam, sir? In the
Sorry,
jaundice? What is the common DD we get in the exam?
common
Jaundice. differential diagnosis. What is the main
No,
differential diagnosis?
you can't tell like that. The thing is, differential diagnosis of jaundice I have given you. So all these four can occur. You can't say which one is the main one. You might get a case of hemolytic anemia, hemolytic jaundice, like a case of thalassemia, or you might get a case of SLE, where you get jaundice. That's hemolytic jaundice. So where you have more of, why I give this slide, this slide. I can't I get rid of this. I want to minimize this, but please. Oops. I'm trying to share the PowerPoint presentation, but I don't know why it's not coming up. Yeah, but so now if you see this one, so what are the DDs? So there are four main categories. Four main categories of jaundice: either hemolytic anemia, hepatitis, this acute causes of liver disease, then chronic liver disease, and the malignancies. So all those diagnoses fall into these four categories. Your malaria will fall into hepatitis category. So you can't say which one is more common. All four types you can get, right? So depending on patient symptomatology that you gathered after asking questions, then you fit into one of those four categories. Understood that? So like if the patient has got more of anemic symptoms, if the patient has got previous blood transfusions, then that will favor hemolytic anemia. The patient has got fever, abdominal pain, um, uh, anorexia, that will favor hepatitis. The patient has got abdominal swelling, leg swelling, a history of alcohol consumption or NASH, then that will go in favor of CLCD. The patient has got severe loss of appetite, cachexia, declums, deep jaundice, then that will be more in favor of malignancy. Understand? Is that correct? Happy with the answer? No response from students. Yeah, understood? Yeah, I think that was a very fruitful discussion. So just to give you heads up, like we will be doing a true mock practical exam also, most probably next weekend, during the next weekend. And then we will bring all these cases and we will do like one, we will give you exam experience, the true exam experience, because I'm a true examiner for like final MBBS for several years, almost more than 10 years now, 12 years. And also I have been an ERPM examiner as well. So we'll be doing that during the next weekend. So thanks for your time. Hope you have enjoyed this session. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you.